But we had a couple questions from the audience we wanted to get to before the break. And a question was for Dr. Hawkins about, you mentioned, steroid can cause sometimes pressure to go up. The question is kind of a two-parter. One is, when you have pills like prednisone for other systemic diseases, is that a risk factor? Do they have to check their eye doctor? And then what are some of the other secondary causes of glaucoma?
Yeah, that's a good question. Often other doctors have put patients on steroids. Most commonly, it's the Nasonex that's over the counter now, or a dermatology with ointment. It doesn't even have to be on the face or close to the eye. And less commonly, oral steroids. So all of those can elevate intraocular pressure, but oral steroids less commonly. But if you are on any kind of steroids, I think you should get an eye exam. And most doctors will not prescribe steroids if you're on glaucoma, or if you communicate to your doctor that you're on glaucoma. And we, as your ophthalmologist, communicate with your doctor that you're on glaucoma. There's a percentage of people that have glaucoma that are known as steroid responders. So it's not 100%, but a good percentage of glaucoma patients will elevate their intraocular pressure with any steroid use. So we try to just avoid that or minimize it. And the second part,
just kind of any other quickly secondary causes of glaucoma?
Many, diabetic retinopathy, having a stroke in the eye that causes ischemia or trauma or inflammation. So a lot of other diseases of the eye can lead to secondary glaucoma.
Great question, great point. Thanks for that answer as well. A question above to both of you on checking the pressures at home. Are there ways? I know we always check a pressure 1 minute out of a 24-hour period every 4 months, let's say. But pressure, we know, can go up and down. Are there ways to check at home? You guys know about those ways?
So there are some companies working on some devices that you can have at home so that you can monitor your own pressure. We sometimes check pressure in the office with an eye care, which is like a little handheld thing that goes up to your eye and it doesn't really feel like anything. They're making a home eye care so that you can check your own pressure. I have exactly one patient who has his own eye care, and it's actually been very useful because he's on steroids for other reasons, and so sometimes his pressure goes up and down, and we don't always catch the high points in the office. And so sometimes when he's on a higher dose of steroid, he'll check his pressure a few times a day at home and then email me with the pressures, and then we can make some adjustments to his medications for glaucoma based on what's going on at home. And we won't detect that if we just check his pressure once in the morning, even once a week. We won't catch all those fluctuations. There's also another company working on a contact lens type of device that would go into your eye, and then that would also be able to measure the pressure at different times of day, even when you're sleeping. So there's a lot of technologies out there that are hopefully coming soon that will let you monitor your pressures a little bit more carefully at home.
Yeah, I've had a few patients at the eye care home tonometry where they kind of you can rent it, and then you can take it for a week and just check your pressures throughout the day, in the morning when you wake up, and see how they're doing. And that could be one of the reasons why patients are getting worse, if their pressures are going up and down. And then also, some people have bought it outright. They want to have it at home as well. So there's different ways of approaching that, but that's a great opportunity. Dr. Hawkins, there's a question here about normal pressure glaucoma, meaning if the pressure's not really high, but can you still get glaucoma, and kind of what are the risk factors for if you have that normal pressure?
Yeah, that's a very good question, and it's a difficult disease, more difficult than regular tension glaucoma, because the pressure readings are normal. However, the optic nerve appearance and the visual field that I showed looks like glaucoma. So it is acting like glaucoma. You're losing peripheral vision. The optic nerve is changing. However, the pressure may be 12. So studies were done that show that for normal tension glaucoma, the treatment remains the same. Lower the pressure at least 30% to have any effect on reducing risk of progression of visual field. So, we still, once it's diagnosed, which is more difficult and usually caught at a later stage because the pressure is always measured normal, then the goal is to reduce the pressure 30% and maintain the visual field by doing those tests, maybe even twice a year, though patients hate that. But
are there any risk factors, like if someone has, let's say, like migraines or something? Are there other systemic issues that can?
Yeah, I mean, we can ask. It used to be, you did MRIs and things like that. That was not very effective, and that a lot of those were negative. But certainly, patients with migraines, maybe sleep apnea, even other rheumatological diseases could be a risk factor for normal tension. They tend to be small, petite women often, and the interesting thing is when the pressure is low and when they go to bed, the pressure becomes even lower, the blood pressure, and then the blood pressure to the blood flow to the optic nerve slows down. So some doctors tell their patients to have, V8 or a bag of potato chips before bed to increase the blood pressure, which will help the eye optic nerve.
I've had that happen too
Yeah.
sometimes. You're like, what else can I do? No. There's actually a company called Equinox, a company called, by a good friend of mine, John Burdall, has these goggles that can actually help blood flow. We think blood flow, as Dr. Hawkins mentioned, the flow of the blood into the nerve in the back of the eye may be compromised in some of these patients. And so by wearing these goggles to help the blood flow at night and also bring the pressure down at night when we're sleeping and lying down might be something that might help patients who have normal pressure glaucoma as well. It's not quite FDA approved yet, but it's called Equinox as well. Oh. I'm sorry?
Can you please restate that because I'm not 100%.
Equinox is the name of the company, Equinox. John Burdall, Berdahl is the name of the doctor who started this company, and they're working on getting FDA approval for these goggles that you wear at nighttime as well. It's called Equinox. They can help. They put goggles on. They can change the actual pressure in the eye with these kind of pressurized goggles, and they can help the blood flow in the back of the eye. It's not quite available yet. They're in studies, but that's something that can help the flow of the blood in the nerve and potentially bring the pressure in the eye down while you're sleeping at nighttime.
Okay, so a related question. What about swim goggles for while you're swimming?
A little different than swim goggles. These have a special kind of a pressurized kind of apparatus, so they wouldn't do the same thing as a swim goggles would do as well. In fact, swim goggles sometimes paradoxically cause the pressure to go up in some patients. So this would be a little different than a swim goggles.
Right, but I was asking you because I'm a swimmer and I don't wear goggles, and I'm wondering if I should wear goggles or if I should avoid wearing goggles.
I mean, for a period, it's a good question. I'm going to talk to you offline. It's a great question. Come get me afterwards because I think that's a wonderful question. Love to get involved with that. But thank you for that question about the swim goggles and wearing them as well. But we'll get to that for sure as well. One more thing I want to talk to you about here, MIGS. We didn't talk about MIGS, and we want to have some time to talk about that, Mary. This category, just briefly describe what has made MIGS different than the traditional trabeculectomy and tubes that you talked about, and when do you incorporate that into your practice now?
So MIGS is microinvasive glaucoma surgery, and it really came out about 10 years ago in the early 2010s. And when it was first devised, it was meant to be less invasive and done at the time of cataract surgery for patients with maybe milder forms of glaucoma. So for example, you're already going to have your cataract out and you have glaucoma and you're on a couple different eye drops, and maybe since we're already in the operating room, already removing your cataract, perhaps we could do something to the natural drain tissue of your eye to help the natural drain drain a little bit better, such as putting a stent in the natural drain or putting a cut in the natural drain. And the recovery process would be just like cataract surgery, and it wouldn't really add anything extra. And the risks would be much less because you're working on the natural drain of the eye, so the risk of a very serious problem related to pressure dropping way too low would not be as relevant. And so in the more recent years, we've come up with more devices that put different types of stents in the natural drain. So there's the iStent inject, the Hydrus. Those are all types of devices that go in the natural drain. There's more devices that cut into the natural drain, for example, the Cahook dual blade or the Trab X, and there's other devices that not only cut the natural drain but also flush the natural drain with the surgical gel. So that would be the Omni device or the iTrack catheter. So there's all these different devices that work on the natural drain of the eye to try to get it to drain a little bit better. And then the goal here is that it's all less invasive than a trabeculectomy and a tube. It's all a quicker procedure and the risks are better. And then there's also a less invasive way to do a trabeculectomy called a Zen gel stent. And when it was first invented, it was intended to be done from the inside of the eye, sort of the same way that you would do a cataract surgery. You plug a little straw that connects the inside of your eye to that subconjunctival space from the inside out. But in more recent years, people have been doing it from the outside in, so we do open up the conjunctiva, so it's not as minimally invasive as it was first designed to be, but it's still a much quicker way to do a procedure that's similar to a trabeculectomy with a better safety profile with good efficacy. And so this is this category of procedures that I like to offer patients who have milder disease that's well controlled on medications, or even if it's out of control serious disease, a lot of these secondary glaucomas, like you mentioned with steroids, or other types of secondary glaucomas where there's something physically clogging your drain, such as pigment or pseudoexfoliative material, these kinds of glaucomas can respond really well to something that makes your natural drain better. And so we don't have to give up on your natural drain and shunt the fluid somewhere else quite yet. We can try one of these smaller procedures, and if it doesn't work, we can always do a trabeculectomy or a tube shunt later. So I have a lot of patients who now start with cataract plus a small procedure or just a small procedure, and if needed, we go to the bigger procedures later. It's been a great development in surgical glaucoma.
Yeah, I mean, it's really revolutionized glaucoma, this whole microinvasive glaucoma surgery space. And, the hallmark, as you mentioned, the hallmark of this is much higher safety. Before, many years, we'd say, wait till your glaucoma was bad enough, wait till you were really getting really, really bad and your pressure is super high, and then we'll take the risk of doing a trabeculectomy or tube surgery. Although they're overall very effective, a little higher risk, as you mentioned. But these new space, this new category, allows us to intervene much earlier. So now if someone is on 2 or 3 meds and not really advanced and having a hard time taking drops, they maybe had that SLT laser and still not where they want them to be, now I can go in there and reopen the drain. And the analogy I use is, imagine the heart. We have something called angioplasty for the heart. We can go in there and balloon up the drainage system of the heart or the blood vessels. Same thing in the eye. We can go in the eye, use a small catheter, that Omni or iTrack. We can go in there and really balloon up and open up the drain and even remove some of the unhealthy tissue, all within a very efficient surgery, no stitches, no patches, very quick recovery. So, Dr. Hawkins, are you doing a lot of those MIGS procedures too? Oh, I'm sorry. Sure.
I have valves in my eye. When you get through it, you cut her off. I flew all the way here to find out
Oh, sure.
what they put in my eye.
Sure. So yeah, we'll get it, definitely.
And you still going through it, but you said this was a question. Let me ask a question.
Sure, absolutely. Yeah. I was just going through the questions here that we have, but definitely, please.
So answer my question.
Sure.
Could you, because you talked a lot, could you talk me through it and show me? Because I flew all the way here 1,000 miles to see, he came from another country. I flew here to see what they put in my eye so that I can kind of find out where to go when I leave here.
Sure.
Because I done lost a lot of sight. I don't have much sight left in my right eye and I want to keep my left.
Sure. I think you had the Ahmed valve, I believe. Is that correct?
Yeah.
Okay. Let's go into that question real quick here for us now. Mary, you mentioned glaucoma surgery in that tube surgery category. You want to describe thank you for that. Again, we'll do our best to answer all the questions, everybody. Thank you so much for your patience. In terms of the Ahmed valve, tell more about, for our patient here, what it is, what's in his eye, what is it doing, and kind of what the follow-up is like.
Absolutely. So in the category of glaucoma drains, there are 2 types of drains, one with a valve and one without a valve. It sounds like you probably have the type with a valve because you said I have a valve in my eye. The valved type of glaucoma drain device is, again, a plastic straw that plugs into the inside of the eye, and at the end of the straw, there's a valve device, and then the valve makes it so that the fluid exiting your eye doesn't exit too much or too fast. The valve is to prevent the pressure in your eye from dropping way too low. And then at the end of the valve, there's a little plastic round plate, and then your eye grows some scar tissue around that plate so that when the fluid goes through the straw, through the valve, it can collect in that space of capsule that grew around the plate at the end of this device. Your body will grow scar tissue around the plate over the years, so sometimes the pressure right after you get the valve might be like 10, 11, or 12, but then it starts to creep up a little bit, and sometimes your doctor has to add more glaucoma medications back, and then sometimes your body can grow some scar tissue that grows up into the valve and clogs it a little bit. So sometimes these valves over time can become clogged or excessively scarred, and then the pressure can go up. And so sometimes the valve might need to be revised, or a second tube implant has to be placed into the eye. After one of these glaucoma valves, you still have to get checked very frequently to see whether the pressure is low enough for you, or if it's not low enough for you and your testing is still getting worse and worse, in which case you might need more surgery. There's also another type of drain device called the bar velt, which is what the other glaucoma patient spoke about having. That one does not have a valve, so the fluid goes out the straw and immediately just goes to that space. And so with that type of device, we have to surgically tie the straw shut so that your body has about 6 weeks of time to grow a balloon of scar tissue around the plate. And then 6 weeks later, there's a stitch that dissolves, and then the fluid goes out the straw and into that new balloon of space. And the balloon there is a little bit larger of a balloon, and so sometimes those non-valved devices might be able to lower the pressure more over the long term. However, those types of tubes don't necessarily work as quickly right away. And so some patients whose pressure is super high, we might recommend the valve one because it works right away, because the valve prevents the pressure from going too low. The non-valved one, there is no safety valve, so the pressure could go too low. So you have to give it some time. Yes, go, yes.
So
Right.
the question was how far apart for the visits to have to be after the surgery? I think that was.
Yeah, immediately after the surgery, you have to be seen very often, like 1 day, 1 week, 2 weeks, 4 weeks. And then once things are stable, we might say, let's see you in 3 months. And then if things are still stable, we might say, let's see you in 6 months. And sometimes when I say that to patients, they might say back to me, I don't know, doc, 6 months sounds like a long time, right? I might want to get my eye pressure checked a little bit sooner than that. And actually, if you say that to me, I'll just say, okay, sure, I'll see you in 3 months, then we all feel better. Because, you have a point. Sometimes the pressure might rise in between those visits. And if you're not getting your eye pressure checked at the eye doctor, we won't know if it goes up. And unless it goes up all of a sudden, you won't necessarily have any symptoms. So you won't know that it's gone up either. But a 6-month follow-up for patients who are very stable, whose pressure has not budged in a long time, is generally okay. But you're right to be a little worried. I would be too. I'd want my pressure checked all the time. Yeah, that's exactly why all these companies are trying to invent like a contact lens or an eye care device that you can have at home to check your own pressure. So they have these things called the home eye care, which you can rent from your eye doctor or just like buy an eye care, but it's not so practical.
Yeah, what I'll do is after this, we'll have a break in a few minutes. I'll stay on stage. I'll give you the number of where to call or who to talk to get those, because not every surgeon or every eye doctor will have these ability to rent it to you. So I can, after this is done, I'll make sure I spend time with you. I want to make sure I answer your questions too. Thank you for that.
That's a great point. Everyone wants to know what their pressure is all the time, and we can't.
That's a really good point. We have a few minutes, and thank you for that. Again, I apologize we didn't get to every question. Just a few more for the next few minutes here. One question was, if you have a tube like an Ahmed or a Barbelt, can you put a drug delivery little implant in those? Yes, you can. If you have enough space in the eye, if the eye is deep enough for that little implant to sit safely without irritating the surface of the eye, then you can put that implant in, that little drug delivery Durista we talked about, in patients, even if they're more advanced glaucoma patients, to get you off that drop at nighttime. So that is something you can do. And then, Dr. Hawkins, a question from the audience on if you have a history of glaucoma, hereditary, like family history, mother, sister, brother, and you have kids and you have glaucoma, how quickly or how scary should it be for them?
Yeah.
In terms of
so I think that's a good question. It depends. If you have sort of the traditional glaucoma in the sense it was diagnosed at age 65 or older, you should certainly tell your kids you have glaucoma and they should get regular eye exams starting at 40 or 50. But if your glaucoma started at a young age, in your 40s, 50, and it's severe, then the kids may want to get checked even sooner than that.
No, that's a great point. Absolutely. Family history is really important. Also, how bad was the glaucoma? How bad did they have surgery? Did your family member go blind? How advanced, how quickly did it get worse is something that also helps us determine how aggressive we want to be of following up the family members. SLT, you mentioned SLT. There's a question from the audience on how many can you do? We said it may be repeated. Can you do it 2, 3, 4, 5 times? And how often do you do it?
So the first time I do the SLT, I'm kind of expecting that maybe in a year or so, a lot of people might have it wear off, and I'm willing to do it a second time. I usually limit it at about 2. I mean, once we get to about 2 times, there's no reason we can't do it a third time. I think I do have one patient where I did it like 5 times because she had pseudoexfoliation glaucoma and she could not get to the operating room. So just out of desperation, we did it 5 times. I don't really recommend it 5 times for most people. I usually cut it off at around 2 or 3 times, and it's usually about a year later or 2 years later where we start talking about having to repeat it. But if we're at that point, maybe the cataracts have gotten a little bit worse, maybe it's time for your cataract surgery, and then we can do a micro-invasive glaucoma procedure at that same time, just to get a little more efficacy than just repeating the SLT over and over and over again.
And first line, do you have to use drops first line, or can you do SLT first right away when you see a patient?
Yeah, in the past, we used to think that you had to do drops first. That's what the eye drops have been around for decades. But now there are all these new trials that say that you can actually do the laser first. You don't have to start with these eye drops with all these side effects and everything. And so I do offer laser first for people who have a new diagnosis of an open angle type of glaucoma, who might not like the idea of having to use an everyday eye drop. And so, and some people don't like the sound of laser, and some people say, oh, laser, that sounds like new and great, so it depends on what you might prefer. Some people say, don't touch my eye with a laser, and some people say, yeah, give me the laser. So it's really up to you. There's not really a right or wrong answer about starting with drops versus starting with laser. The big danger about starting with laser is you don't want to think that you're cured, like I had glaucoma, I had a laser, I'm good, because you're not, and you still have to get monitored. So that's one of the dangers. If you're not on an everyday eye drop, you might forget that you even had the glaucoma, and then 5 years later, you might be back in our office and your pressure might be too high, and you might have lost vision, and then it would be too late to get that vision back. So even if you start with laser, you still have to keep up the very frequent follow-up visits.
Yeah, and there's a question about dry eyes. Why do you get dry eye from glaucoma drops? The preservatives in the dry eye and the glaucoma drops can irritate the surface of the eye, the glands that produce the oils to protect the surface of the eye. And even the chemicals in the medication itself can irritate the glands in our lids that produce the oils to prevent dry eye. So that's why we like to get people off of drops or use preservative-free sometimes for those patients. But also SLT, it's a great way to kind of get you off the drop in a safe way and then see if that'll help prevent you from getting worse in terms of dry eye. The last question for the sake of time here was a question on plateau iris, a very specific condition where a patient already had narrow angles, had a laser for that, but is still having pressures and has something called plateau iris. There's a question, is there something to do for that?
Yeah. That's a tough condition because you think you've got it figured out. You do the peripheral iridotomy and, as I say, you think it's one and done, but it isn't. So those cases, sometimes cataract surgery can help or, traditional drops that are needed and not laser.
Yeah, absolutely.
Yeah.
And I apologize if we didn't get to every question. We'll hang out here for a little bit there. We want to give you all time also to have a break and have some refreshments. There's free refreshments for everybody. There's also those exhibit halls. I think the eye care people, the home tonometry people are here, and the My Eyes are here. So please go visit them. And the Alcon booth has these virtual reality kind of goggles to actually kind of help educate you on glaucoma. So please feel free to visit the exhibit hall, the booths, and also have some refreshments. And then we'll come back for some more great discussions. And we'll be up here if you have any other questions.